when you're done talking to Dr. Lodge, then you're going to go up to the PCICU because anesthesia will be getting him ready to transport up there.
Okay.
They'll transport him up to the ICU, give report to the team, get him tucked in, and then they'll come and get you.
About another hour before.
About another hour.
Yeah.
Yeah, so after you talk to Dr. Lodge, just head up there to the PCICU and just kind of wait because the nurses know we send you there and they'll come and get you as soon as they get him settled.
Okay.
Okay? So when he goes in to,
Yes.
you know, he's going to go in, he's going to make let's see, going to make an incision in the right atrium. And then he can look down between this valve right here, and he can see this hole, and he can just
How does he get to his heart?
through a median sternotomy. I'm sorry. Let me back up. Incision here, up and down. Right. You can feel a little notch where your sternum ends, and there's a little notch here. Start at the notch and kind of down to about here, just to make an incision. And then the breastbone, he cuts through the breastbone so that he can open that up, so the heart is right there.
Okay.
Yes.
That sounds painful.
Well, he'll be sound asleep.
Well, he'll be asleep.
I know, he'll
But
be sound
I'm
asleep.
saying when
and afterwards, we'll be giving him pain meds.
Okay.
And you will be surprised, and I've been with lots of parents whose babies have had surgery, that babies are very resilient. And by the time he goes home, he isn't really even going to need narcotics. He's going to be on Tylenol, and he's going to be eating and acting and
Just like
looking at you and acting totally normal. And you're going to be like, how's this baby acting so normal when he just had open heart
That was
surgery?
my main concern.
Now, the first
they don't know nothing about babying in any way. They
don't. And he's not old enough like bigger kids. We have to say, don't let them ride their bikes. Don't let them skateboard. They might fall. All you have to do with him for his sternum healing is instead of picking him up under his armpits, lifting him under his back and bottom like a little scoop.
Okay.
That's it for 6 weeks while it heals. Because babies aren't carrying heavy things. They're not, we say 2 weeks until he could do tummy time. But if he rolled over, he's not going to break anything. It's fine. You know what I mean?
because he's just at that point
Right.
and he
And
wants
so
to
then
roll.
he may.
So
And
this-
it might hurt a little bit and he might cry. And then you just flip him back over.
So is the sternum going to fuse on its
Yeah,
own?
no,
back-
we put it back together. So after he's repaired everything, he pulls the suture, the two pieces, say this is the sternum and it gets cut in half. It's like this. Pulls it back together, right? And sews it together with it's really thick suture thread that kind of looks about as thick as fishing line. Have you ever
Okay.
fished?
Okay.
And then, but it dissolves. So it's meant for the body to absorb it, but it takes several weeks. By the time it absorbs, the sternum's well healed.
Okay.
And then he closes the skin in layers under the skin, so you really won't see sutures
That's what I was looking at.
at the skin line. But there's a lot of sutures. He closes it in 3 layers.
Okay.
And so the sternum's closed, the skin's closed. At the surface, you'll see some Dermabond skin glue. Has kind of a purplish color, and then of course there'll be a bandage over it, and we'll leave the bandage on for a couple days. But everything will be closed up by the time all those sutures dissolve. It's well healed.
Okay.
So the main thing is just the way you pick him up.
That's really it for little ones because he's not doing any activities that could. He's not lifting
So
heavy
what
things.
happens if you happen to just forget and like pick him up like that?
Well, honestly, you're not going to break anything. He might cry because it might hurt.
Oh,
Because
okay.
then he's putting his weight. If you lifted him, then all his
Yeah,
weight is
yeah.
kind of putting pressure on that sternum,
Yeah.
and he might just cry.
Okay.
Okay.
And then you would just kind of readjust because
All right.
but you're not going to break anything. He's not going to break.
Okay. So we got his chest open. We got his sternum open. Now what?
He's going to go in. He's going to make an incision in the right atrium. He's going to visualize this hole right here through this valve, and he's going to patch it. He's going to sew a patch on it. So it just will not be a hole anymore because he's going to sew a patch on it.
Okay.
Okay? So then that's closed off.
So meantime, he's gonna put a tube.
And then he's gonna put what we call a conduit.
Yeah, okay.
And I'm not sure, we'll have to ask him, and he may not know till he's in there exactly what size and what type he's gonna use. There's a lot of different options.
Okay.
So we'll ask him, and he'll probably know after. It usually is a partly game time decision, and he will probably though have an idea of about 2 or 3 options he's gonna go with, and he'll tell you afterwards.
So now when he come home, would you call that again?
The sternum,
Sternum.
Yeah, that'd be closed, right?
Yeah.
everything will be closed.
Yeah.
Yes,
They're not gonna
everything will
send
be
him home
closed.
with his chest open.
So there's, because I was getting some kind of impression they're gonna kind of like leave it open and to see if it was gonna be any swelling.
Well, they
So
will
some
leave it open
babies do
for.
that. Sometimes we do that in little babies. I don't think we're gonna have to do that with him. Now, that's never it's always a small possibility, but that's typically something that we do in babies that that are repaired in the neonatal phase, which means like less than a month old.
Okay.
Oh.
So then
we
once
do
he's
sometimes.
done, his chest won't be partially open.
He
and then
shouldn't
we have
need
to do
to be.
another
Now,
surgery to
now that
close it.
being said, if Dr. Lodge is concerned, the things that make us leave a chest open are worried about swelling and worried about bleeding. And little babies tend to be bleeders, and even when they're a month to 2 months older, they do a little better with clotting their blood. If for some reason he's concerned about bleeding, he might decide to leave it open, but I think it's less likely.
Well, being that he's on aspirin,
Yeah,
his
aspirin.
blood's not
Aspirin
clotting.
aspirin is a very, very mild
Okay.
anticoagulant. It's not enough to affect
Okay,
surgery, bleeding in surgery.
got it. Okay,
It's not like if he was on something like Coumadin or something.
okay. All right. Okay. What's he gonna look like?
Well, afterwards, he's going to come back. He's going to have to bandage over the incision. He's going to have some temporary pacing wires. One of the risks of this surgery, because where we sew this patch right here in the ventricular septal defect, the way that your heart is basically a pump and an electric system, and how fast it beats is based on the electrical conduction system. So that runs right down the center here and loops around the ventricles, and that tells it how fast to beat. Okay, so when you sew here, you got to make sure you put your sutures deep enough to hold the patch in place, but not so deep that you interrupt that conduction system. So anytime we patch a VSD, we leave temporary pacing wires that are just loosely, they're sutured to the surface of the heart, and then they come out where the chest tubes come out, and we can pace him externally with a little box, like a little temporary pacemaker, if needed, if there was an issue with the conduction system. If there's an issue with the conduction system, it usually resolves on its own. It's just because it's of swelling and inflammation from the surgery.
Okay.
If it didn't resolve and it was permanent, he would need a pacemaker.
Okay. And you won't know that until after.
We won't know that till after the surgery. What usually happens is what usually happens is there's no problems. It's only about 2% that there's any problem. Of that 2%, they usually resolve with some steroids and some time while the swelling goes down. And then the heart conduction is fine. And we pull the wires and we go on with our lives. If it doesn't seem like that's going to happen, then you would need a pacemaker. But that wouldn't be something we'd know for at least 7 to 10 days.
Okay.
But it's a risk whenever we patch a VSD. So there will be temporary wires that you can see. They're very thin. And then there will be chest tubes, because whenever we go into the chest cavity, we got to give away for bloody kind of watery drainage to get out. So there'll be chest tubes in place, draining fluid. As soon as there's not much, we pull them. We pull the
But
tubes.
that would be before he come home anyway.
Oh yeah, he would not come home with chest tubes or wires. Yeah, no.
Okay. What are some risks?
The main
Some
risk.
things that can make it go wrong during the procedure.
So I guess the biggest risk with this particular surgery would be the risk of the heart block and the need for a pacemaker. That's one of the things with this surgery. The conduit, there's typically not a lot of risks with the conduit being put in. Over time, we have to watch that conduit.
Right, because
make sure it
he'll
doesn't
outgrow
get
it.
stenotic, make sure it's not he doesn't outgrow it. That'll be Dr. Whittam. We'll
Follow
continue
it.
to see him. Yep.
Okay.
And then, of course, bleeding and infection is always a risk whenever we do surgery. Now, we have blood in the room if we need to give it, and we give antibiotics within an hour of start time and through 24 hours post-op. So we do prophylactic antibiotics to avoid infection, and of course, sterile technique.
Okay.
But those would be the two most common. This is done on the heart-lung machine. We need the bypass machine, so the heart is still. Just like you wouldn't work on a car engine with it running, right? We need the heart to be still. So we have a bypass machine that takes the blood away from the heart, adds oxygen to it, and puts it back into the body, just
So
like the
his
heart
heart's
and
not
lungs.
gonna be beating.
So his heart is still, so he can sew the patch in.
Okay. But the bypass machine is going to make sure he gets the oxygen circulated
Yep.
and everything.
Yeah, the bypass machine does all the work so that we can safely operate. And then when we're done, we just take the machine off, and his heart starts back up and pumps on its own. And
Is there ever a case where it does not start back up?
well, we can shock it if we need to. We can shock it back into starting, but that's not typical. But we could.
Okay. Okay. So
How long will he be in the hospital?
Well, I would say he's probably going to be in the operating room I would say probably 5 hours or so is a good bet. We would hope he was starting by 8. I would say you'd probably see Dr. Lodge early afternoon.
Okay.
Okay, and then probably see Justice 2-ish.
Okay, so his stay.
His stay,
Yes.
he'll probably be in the ICU. So sometimes after this repair, there can be rhythm issues, right? There can be sometimes there can be a little tachycardia too, where the heart wants to be a little faster than it should, and we need meds for that. So I guess it'll depend if he has no rhythm issues.
Yeah.
Probably a couple of nights in the ICU.
Okay.
And then out to our step down or floor where he'd go home from. I would say the whole hospital stay,
Yeah.
probably a week to 10 days.
Really?
No.
You think longer than that?
I mean, I always try to prep myself for him to be longer
Sure.
because when he had his stent placed, we were expecting maybe a 2-week turnaround and it turned into a month.
Oh, gotcha.
So,
well,
yeah.
I'll tell you, if you want to, I mean, if there was a lot of issues with heart rhythm and he had to go back and have a pacemaker, sure, it could be 2 weeks.
Oh, okay.
Okay.
That's good though. I mean,
And that's how you address the rhythm issues. Those are one of the
Well,
common
it depends
issues.
on the it depends on the problem with. So there's some rhythms that are too fast can be controlled with meds. Rhythm that isn't communicating because of this patch, we watch and wait and see. We temporary pace till we watch that rhythm to come back. Sometimes we give steroids because that helps with inflammation, and some of the problem is from inflammation, and we want to decrease that. Things are inflamed just because we've been in there doing surgery.
Okay.
So your tissue responds by, just like if you cut your skin and you got stitches, it would be swollen. It would be swollen,
Right.
kind of sore.
Yeah.
So that's the same thing. When that swelling goes down, then sometimes the heart rhythm comes back. Most of the time, that's what happens.
Okay.
So we give it a week to 10 days for the watching and waiting and the steroids to work. We don't make a decision quickly because it's just something that takes time.
You gotta watch. Okay.
Yeah, before we decide, we're going to take this kid back and put in a permanent pacemaker, we give it a decent amount of time to resolve on its own.
Okay. Okay. Any other issues that could come about after surgery other than the rhythm issues?
I would say those are kind of the main ones. I would say that.
Oh, yeah, I know I have. I'm sorry. I didn't mean
No,
to
that's
do
all
that.
right. What?
The breathing tube and,
Yes.
and the feeding tube. This is a concern of mine.
So the breathing tube. So what is his diet like now? What does he take?
Right now he pulled his NG tube out. So
Okay.
before he was being fed through the NG tube,
Okay.
and he should be at about 7 ounces every 4 hours.
So when's the last time he pulled out his NG tube? When
About
did
a
he-
week ago.
He pulled out a week ago. So you've
Yeah.
just been doing oral feeds.
Oral
Okay.
feeds, but he has not been gaining the way he should. So I'm going to put the NG tube back in today
Okay.
to make sure that he.
When he's doing oral, like this whole past week, how successful has he been? What's he taken?
He will take anywhere from. He started out. He starts out really good. Like when he first took out his tube, that's why I didn't put it back in.
And this
he
is formula?
Yes.
Okay.
He was taking about 7 ounces.
All by
Between
mouth.
5 and
Okay.
7 ounces by mouth. And
And
then he
how often?
gradually started to slow down. And that was every 4 hours. Since then, he's going anywhere between 3.5 to 4.
Still about every 4 hours.
About every 4.5 to 5 hours.
Okay.
Yeah.
And does he just get tired?
Yes.
Okay.
So he starts out really good. He'll take those long sucks, and then after about 2 ounces, he gets tired.
Okay.
And so we have to kind of play with him to get him to drink the rest of it,
Okay.
and give him frequent breaks, and then he'll take about a 2-minute break and he'll suck a little bit more,
Okay.
and then another
Okay.
2-minute break and he'll suck a little bit more.
Do you think he has, have you weighed him? Do you think he's lost weight, or do you think he's just plateaued and
He's
not
kind of
gained?
he's plateaued.
Okay.
Yeah.
Okay. All right. And he's on a 1/4 liter
Yes.
of oxygen, and he's been on that for how long?
Since I would say he got oxygen. He was because he came home at 6 weeks old, so it's about 2 weeks after the ductal stent placement.
Okay.
He kind of started having DSATs and never fully recovered
Okay.
from
All
it.
right.
He does really good. Some nights I wake up and he pulls his oxygen out, and I'll have him hooked up to the monitor, and the monitor won't sound because usually I have
Gotcha.
it loud enough to where if it does happen in the middle of the night, I'll wake up. So he'll take it out in the middle of the night, and I'll wake up and his sats are like 83.
Okay.
So, you know,
Okay.
but however, he has some nights where he can't stay above 75
Okay.
or,
Yeah.
you know, so it just fluctuates.
Yeah. Yeah, well, I mean, it's definitely time to do the surgery, you know, because he's outgrown even what the stented ductus can give him, you know, because it's just bigger.
And that's probably why his sats are
That's why.
hanging out around
Yep.
that low range. Okay.
That's
because
why.
when he does start to desat, he's not turning blue or anything. He might be taking a little bit more to breathe.
Sure.
But other than that, you know, and he also desats after he eats,
Okay.
typically, because he has acid reflux.
Okay.
So the milk coming, I don't know how that works or how that affects the sats, but after
You'll notice that after he eats.
yeah, after he
Okay.
eats, it's harder to get his sats to stay where they should.
Okay.
So we elevate them, or we try to, you know, keep them lifted up at least 30
that helps
minutes,
when
and
he's
it does
upright.
help when
Okay.
he's upright.
Okay.
So
And
I'm
does he take
hoping.
omeprazole or anything? Is he on a reflux med?
Yes, Zantac.
Zantac,
But I've
okay.
been giving them gripe water.
Okay.
Less Zantac, more
Okay.
gripe water, because Zantac kind of it does hinder his appetite.
Okay.
So I've been trying to, you know, kind of wean him from that, but I don't know. So
Okay.
those are some of the things too I was thinking about, you know, after surgery, are these things going to be, you know, do we think it's going to be resolved, or is he going
His
to
oxygen,
continuously?
his oxygen saturation will certainly go up. He's going to have this conduit, which will be much bigger, allowing blood there, and no blood will be going across that VSD because he's, you know, it'll be patched.
repaired.
Yeah, so his oxygen rate, his oxygen level will certainly go up. He shouldn't need to be monitored, honestly, at home afterwards when he's fixed.
Okay.
The reflux, sometimes a lot of babies with heart defects just struggle with reflux, and so we'll have to see how he does afterwards inpatient with the meds and his feeding, and as we get him like out of the ICU and to the floor where he's going to go home from, kind of seeing how you think he seems, how, you know, how the team thinks he seems, how he's eating, if you think, you know what I mean?
Yeah.
You know him best, so we'll see.
Okay.
I wouldn't be surprised if that med stays on.
Okay. And that's fine.
Yeah.
Dr. Woodham mentioned, because he was scheduled for G-tube surgery about a month
I
ago.
saw that, yeah, and then
Dr. Woodham mentioned that if he's not, because he's been with the NG tube for so long, they don't want him to stay with the NG tube that long, so they may consider doing G-tube surgery.
Okay.
How likely do you know, or is that not your thing?
Well, I think it just depends on how he does after the surgery. He's certainly, any amount of feeding takes a little bit of a hit as far as, because he can't eat for some days.
Right.
So it's gonna be a little bit of time before he can get back into practicing his oral. And so we certainly will start with an NG feed, you know, with little trickle bits and an NG. We'll start with that, and then we'll see how he's doing in allowing him to PO with you.
Okay.
And, you know, and we'll have speech therapy
Yeah.
come, occupational therapy, and work with him and see how he's doing. So it's kind of, at that point, kind of a bigger team decision based on everyone's we have a nutritionist that rounds with us. There's a lot of people involved. So to get him on the right feeding regimen, and then we'll just, as if we really think that's the recommendation, we'll just talk to you about it.
Okay.
And our cardiologist will be in touch with Dr. Widom. You know what I mean? Like, we don't make decisions on our own. Like, whoever's on for cardiology would call Jen Widom and be like, "Here's what we're thinking," you know, and then she'd weigh in.
Okay.
So it sounds like to me, I'm looking at it that this here when you finish